everyone. How are we doing today? Great. TGIF? Okay. Well, I just have two really brief announcements, if you don't mind. One, there is no live streaming of this program today, so you are getting this firsthand. The normal link, the go.osu.edu, can't do the live stream today. However, you will be able to access it after this program. So if you just go to this website, the Health and Wellness Lunch and Learn link right here, you'll be able to view it at any time with your OSU login information. I'd also like to bring your attention to our next Lunch and Learn program that we're having on sustainability and healthy buildings, how to create a healthy work environment and what to look out for if you have an unsafe building environment. That is at Miling Hall 160 from 12 to 1 p.m. on November 17th, so we hope you can join us there. And now it's my great pleasure to introduce our speaker, Dr. Amy Kerger. Amy Kerger received her medical degree from Edward Via Virginia College of Osteopathic Medicine in 2008. She completed her residency at Doctors Hospital in Columbus from 2009 to 2013. And then she completed her fellowship at University Hospital right here at the Medical Center from 2013 to 2014 in breast imaging. Her division is diagnostic radiology, and she's an assistant professor of breast imaging at the Stefanie Spielman Comprehensive Cancer Center. So please welcome Dr. Kerger.
Hi, everybody. Thank you, Lauren.
You're welcome.
Can you all hear me okay? Let me know if the mic cuts out or something. I'm going to put it in my pocket because I sometimes wander around the room. So, all right, so today we're going to discuss breast cancer risks. What is breast cancer? What are your risk factors? Some of the genetics, family history, gene mutations, things like that. And then we're going to talk about breast cancer screening and kind of the controversy surrounded around that, and figure out what's right for you and what you need to do and what maybe you need to tell your friends and family and things like that, and answer any questions you might have. So I first want to tell you I don't have any financial interest or other relationship with any commercial organization that may have interest in the content of this presentation. Any pictures I show you of like a machine or something just happens to be what we use at the breast center. I'm not employed by any of those people. So today what we're going to, like I said, we're going to talk about risk factors. We're going to talk about breast density because that's kind of a new hot topic, something I've spoke about quite often on the news and in magazines and things. Breast cancer screening and the recommendations for breast cancer screening, which is another topic that I've been interviewed for multiple times, especially come October time usually. So breast cancer. 1 in 8 women develop breast cancer in this country every year. So 12.3% lifetime risk is the average risk for a woman who has no family history, no major risk factors, things like that, just everyday person, no gene mutations, anything like that. So that's today. Back in the 1970s, before we started a screening program in this country, the risk was 1 in 11 women. So we've definitely improved upon that with our screening program. In 2015, which was like the only place I could find like data on this, so I guess we have to wait a couple more years before they'll let us know about 16 and 17. There were 231,840 women diagnosed with breast cancer, and of those women, 40,290 died from breast cancer in this country. In 2008 to 2012, the median age for a woman to get breast cancer was 61. We're still right around that kind of age group for the median age. That means we have women who get breast cancer older, and we get women who get breast cancer younger. And we'll touch on that in a little bit. Between the ages of 60 and 84 years of age, breast cancer is more commonly seen in Caucasian women. But the incidence is higher in African American women when you're talking about getting it younger, under the age of 35, 40, and they tend to have more aggressive cancers when it's at that age. So let's talk a little bit about risk factors. These are your lifestyle risk factors. These are things that you can actually change to improve your chances of not getting breast cancer. And as we go through these, you'll see a lot of these are things you can change to improve your chances of not having a lot of medical problems. And they should look somewhat familiar, such as drinking alcohol over excessive alcohol intake. I mean, that covers like a wide range of medical problems. Being overweight or obese, especially after menopause with breast cancer, because obviously if I told you the median age is 60, breast cancer more commonly happens in women after the age of menopause, right? So if you're obese or overweight after that age, problem. Obviously being obese or overweight can cause a whole multitude of other health problems like diabetes and heart disease and all this other stuff. So, exercising and eating a healthy diet and all that helps with just about everything. Being sedentary, which obviously probably lends to being overweight and obese. So, and as we've all probably seen recently in the news, the more sitting you do for your job, the more chance you have of dying because you sit too much. And that's sedentary lifestyle, which I tell you as a radiologist, it's a problem for me. I have to remember to get up and walk around because that's what we do all day. So another one is no children at all, or you had your first child after the age of 30. Some people can't help this. This is not one maybe you can change readily if you don't want kids, not a reason to have them. But I fit in the after 30 category with having children, so I guess I'm kind of stuck. But I had medical school and residency and a bunch of other stuff, so life happens. So if that's your only big thing, I think you're probably okay. Birth control is small risk factor, really small. And that's really kind of throwing it into the categories of having IVF and things like that. Like the more hormones we throw at you, taking a birth control pill for parts of your life is probably not as big of a deal. And there's more research coming out on that, but it's kind of thrown in there as a little risk factor. And then hormone therapy after menopause, meaning you went through menopause and now you're taking estrogen and progesterone to try to balance out the side effects from menopause. We had a very big spike in that in like the 80s to 90s with Premarin and Provera. We still use it, but more sparingly in women. We used to hand it out like candy back in those days, and then we found out, oh, look, these women are now getting breast cancer. So we kind of cut that back. So here are the risk factors that you have no control over, okay? And we're going to go through each one of these. So one is you're a woman. So being a woman just is a risk, carries a risk for breast cancer. Aging, which none of us can stop, no matter how hard we try. Inherited gene mutations, which we'll touch on in a little bit. Family history of breast cancer, 15% of patients have a family member who's had breast cancer, and we'll go into when you really need to worry about that more or less, but that is a risk factor. Personal history of breast cancer. We talked a little bit about Caucasian women developing breast cancer after menopause more commonly than African American women, but African American women less than 45, you'll see a much more prevalent African American population getting breast cancer in those age groups. If you're Asian, Hispanic, or Native American, you do have a lower risk of developing breast cancer or dying from breast cancer. Now, that's not saying you can't get it. That's just saying you're at a lower risk than the rest of us. I think, American diet and living in America and doing, a hustle and bustle and everything else, kind of, people come from other countries. It kind of, after so many years of living here, you kind of fall in line with the rest of us with your risk factors. Dense breast tissue, which we're going to touch on in a little bit and go into a little more detail. Having multiple benign biopsies. Now, that's not saying you've had one benign biopsy, come back, or you've had even 3. It kind of depends what those biopsy results are, and your doctor can help decide, if you've had multiple biopsies, if that's really a pertinent risk factor for you. And all of these risk factors, some carry a little more weight than others. So this is a discussion, for you and your doctor to figure out, where your risk really lies. Having 3 of these might not mean as much as having 2 of them, depending upon what they are. Personal history of a high-risk lesion, meaning you've had a biopsy and an excision for atypical ductal hyperplasia, atypical lobular hyperplasia, lobular carcinoma in situ, FEA, things like that. Those are called our high-risk lesions. They're things that we find early, and it can eventually become invasive breast cancer with time. So usually if we find that on a biopsy, we have it excised. So having had a high-risk lesion is a risk factor. If you've started menstruating before the age of 12, or if you had menopause after the age of 55, mostly because if you think about that, if you started really early with your periods, and then you had periods way later in life than most people, you're exposing your body to more hormones that float around. Because after menopause, our hormone levels drop. Before menopause, they're down, or before you menstruate, your hormone levels are down. So you have a longer lifetime of hormone exposure. So prior history of radiation to the chest, we talk about this a lot. People used to give mantle cell radiation for lymphoma many years ago. We've not done that in quite a long time, so I don't see as many patients with this, but there are still some people out there who've had that radiation when they were younger to the chest for this lymphoma, so that puts you at a higher risk for developing breast cancer. And then exposure to this diethylstylbestrol, or we call it DES, as you can say why the name is really hard to say. It's an estrogen-like drug that was given between the 40s and the 70s that ended up causing a lot of problems for multiple things, but an increase in chance of breast cancer is one of them. So let's talk a little bit about genetics. This is something that I find when I have patients come to see me and I tell them they need a biopsy. I get a lot of, well, I don't have any family history of it, so it can't be breast cancer. And so I want to talk a little bit about when you need to worry about your family history, what breast cancer genetics are, and what are really your worry for this. So just because you don't have a family member or you don't think that there's a breast cancer gene mutation in your family doesn't mean you can't get breast cancer, because 10 to 15% of all breast cancers are genetically linked, but that means 85% of breast cancers have no genetic or family link. So they are what we call de novo. They just pop up out of nowhere for whatever reason. Now, some of those probably have gene mutations we haven't found yet, but since we haven't found them, we can't put a name on them yet. But a lot of them are, I don't have family members, I don't have this, that, so. But it's also a very small percentage, which there are a lot of women out there who don't get screened because they're like, well, no one in my family has ever had breast cancer, so I probably could never get it. So I want these numbers to show you that just because no one in your family ever didn't have it means does not mean you can't be the first. And it doesn't mean that you have to have the gene. So what is this gene we keep talking about? The one most common one that have two separate numbers is the BRCA gene. It stands for breast cancer gene 1 and breast cancer gene 2. So we always hear about the BRCA gene being the mutation of choice that everybody talks about, and there's many others that we're not going to go into today, and we'll touch on that here in a sec. But the BRCA genes actually are genes that you all have and I have, and they help keep our cells function. When there's a cell in the breast or in the ovary that gets damaged, then the BRCA gene is supposed to come along and fix it. It's like a little mechanic. But when you have a mutation of this gene, that means it's not fixing the cells when they get damaged. So that's where the cancer cells can then just kind of wreak havoc. So that's a problem because your body's not naturally going to heal itself, basically. So those are the two that we hear about most often, and that's the two that, when people talk about that, they're the ones in the news that are most commonly noted. So together, these two gene mutations account for about 20 to 25% of all breast cancers. Hereditary breast cancers, and about 5 to 10% of all breast cancers. So of the hereditary breast cancers, of the gene mutations we know of, this is about a quarter of them. And of all breast cancers, it's about 10 to 15% of all breast cancers, or 5 to 10, I'm sorry. In addition, they account for 15% of all ovarian cancers. So these two mutations also carry a risk of ovarian cancer with them also. These mutations cause people to get breast or ovarian cancer at much younger ages than the average, so that median age of 61 doesn't apply to people who have BRCA gene. They tend to get these things younger. Ovarian cancers we tend to see in the 60-year-old age range also, most commonly in people who don't have a gene mutation. But if you do have a gene mutation, you're likely to get this younger. 55 to 65% of the women who have BRCA1 mutations and 45% of the women who have BRCA2 mutations will develop breast cancer by the age of 70. So think back to what I told you, the average person has a 12.3% lifetime risk. I'm telling you that someone with BRCA1 mutation is a 55 to 65% lifetime risk, and someone with BRCA2 is 45% lifetime risk. And then about 1.3% of women in our general population, average risk women, will get ovarian cancer sometime in their lifetime. But someone with a BRCA1 mutation has 39% chance of getting ovarian cancer, and someone with a BRCA2 mutation has 11 to 17% chance of developing ovarian cancer at some point in their life before the age of 70. Oh, come on. So here's a list of things that if you see something on this list that you recognize for yourself or your family, this is telling you, hey, maybe I should go talk to my doctor and maybe see a high-risk clinic. We run a high-risk clinic over at the Spielman Center. You meet with a doctor. They'll go through all your risk factors. They'll run you through a risk calculator. There's a lot of risk calculators online. The Gale model is one people talk about all the time, but it's real simple to use, but it tends to give a higher risk to people than really they have. So there's models that we use in the high-risk clinics that are much more laborious, however, give you a much better number for your risk factor. So if you have a blood relative, grandma, first degree aunt, not like great aunts, great grandparents, mom or sisters that have had breast cancer on either side of the family before the age of 50. So menopause is kind of like our cutoff. So if they're premenopausal, we're a lot more worried about genetic mutations than if they're postmenopausal. And the number 50 is kind of given as a median age. But there are some people who, as we just said, you can not go through menopause till 55. So if you happen to know that about your family member, you know, that's important, is the pre or postmenopausal status. But if not, if they're before the age of 50, you can almost guarantee they're probably premenopausal when they had it. If they have breast or ovarian cancer on the same side of the family or within one individual in your family, that's a concern. If you have a relative with a triple negative breast cancer. So when we look at breast tissue and we have cancer, we look at this estrogen receptor positive or negative, progesterone receptor positive or negative, or this HER2, which is a human epithelial growth factor, positivity or negativity. So if all of those are negative, then it's a risk that maybe they're a genetic mutation. Not always, it doesn't, like, it's not a slam dunk, but these are things where if these are parts of your family history, we need to have a talk. There are other cancers in your family besides just breast. And here's a list of them: prostate, melanoma, pancreatic, stomach, uterine, thyroid, colon, and or sarcoma. If you have a multitude of these kind of scattered throughout your family, you know, with a breast cancer popped in there and ovarian cancer, then you probably need to talk to somebody, because all of these, there's a lot of other gene mutations that besides the BRCA mutation that kind of filter in with all of these other cancers that can actually increase your risk for breast cancer. And in fact, there was a study that just came out the other day, like sometime this week, that they found 72 gene mutations that have a link to breast cancer. I think we have about 20 that we test for. So there's a whole bunch more, and all they did was find them. Now they have to go back and kind of research how do we test for these, what are they? So there's probably a lot more coming down the line. So when you get tested, you'll be able to see. Now, if you have any of this stuff in your family history, but let's say your grandma who had breast cancer, your mother, whoever, is tested and they come up negative, if you have a whole bunch of these and an increased lifetime risk, we kind of still treat you like you have a gene mutation as far as your screening protocol, okay? Women in your family who've had breast cancer in both breasts is a risk. If you're of Ashkenazi Jewish heritage or Eastern European, you have an increased risk for breast cancer. African American diagnosed with breast cancer under the age of 35. If there's a male in your family that's had breast cancer, that's a pretty big red flag, and men can get breast cancer. It's 1% of the population, but it does happen. And if there's a known gene mutation in your family, obviously, now we have to worry a little bit more. So women who inherit the BRCA1 or BRCA2 mutation may or may not ever get breast cancer themselves. You know, just because you have the gene doesn't mean you're definitely getting breast cancer, but you have a much higher risk of it. But a more important thing to know is you can pass that down to your children, boys and girls. So 50% of them will have a child with this mutation. 50% of your siblings, full siblings, 50% of them will have a gene mutation. If they're half siblings, it can be 25%. So if you have a positive test, you should start screening earlier. And a lot of times then we want to either test the family members or just assume that they possibly have that. A lot of times they recommend if, you know, mom or grandma or whoever had the breast cancer, you know, premenopausal, we recommend they get tested because, like I said, only 50% of the offspring and 50% of the siblings will have the gene. So what if you test you and you don't have it, but let's say your sister does? So the person who had the breast cancer is most likely to be carrying the gene. If they're not around anymore, then you can get tested, and that's just fine. So what do we mean by we're going to change how we screen you? Okay, so the NCCN guidance, which is the National Cancer Committee Network, which is kind of like the people who make the Bible for all cancers and how we treat them and what we do and how we screen for them, they recommend that at the age of 18 for someone who has either a really strong family history or has a known BRCA mutation or other mutation that has them an increased lifetime risk, that you just have breast awareness, meaning you know your breast. You kind of, we call it breast awareness. We don't necessarily talk anymore about, you know, checking your breast yourself, but breast awareness. You know what your breasts feel like. You know if something's kind of off. and you go get checked out. Between 25 and 29 years of age, we recommend an annual breast MRI. We used to do mammogram with that at those age groups, but we find that the mammogram is super dense usually in these, and we're going to talk about breast density, but it's harder to see through when the breasts are dense. And so when these women are that young, we're radiating them with not much of an outcome from the mammogram, so we just do the MRI at that age. And then if we see something in MRI, we can backtrack it to the mammogram if that's necessary. But if you can't get the MRI, let's say they have an implant that causes them a problem to go in the MRI magnet, they're claustrophobic and just can't get in the MRI even with Valium or some sort of anxiety med, then we can always just do a mammogram. And you're still getting a clinical breast exam with that too. So you'd be seeing someone who is specialized in breast to get a clinical breast exam yearly, or every 6 to 12 months, I mean. So from 30 to 75, then we want you to get an annual mammogram and a breast MRI. Why should I get a mammogram? Well, at this point, your breasts probably are much easier to see through and be able to diagnose on the mammogram. And mammography is the number one way we know, screening-wise, that we've decreased morbidity and mortality from breast cancer. So it's the one thing that's been proven. MRI does a really great job, but MRI does find a lot of things that we maybe could see on the mammogram and go, oh, that's been stable for a long time, or it's benign. So we like them together, at least within a 6-month period apart. A lot of people, when they get mammogram and MRI together, when they're high risk like this, will get the mammogram and then 6 months later we'll do the MRI. You can do them both at the same time, but a lot of people like that 6-month period apart because you're kind of screening the breast at 2 separate points through the year, kind of giving a little extra feeling of, this is okay. I've had them checked a couple times, plus you're getting those screening clinical exams where you're going to somebody and they're palpating too. So then we're covering the bases a little bit better. After 75, they kind of say management on an individual basis. So it's kind of based on, how you're doing physically, how your health is. Do you feel like, if you have another disease process that, may take your life in the next 5 years, is it really worth you having to worry about this too? But if you're super healthy, you may live another 20 years, then probably screening would be beneficial. So it's kind of a discussion with your doctor at that point on should you continue screening or not. And then women with the BRCA mutation, let's say you do get breast cancer and we treat you, and you still have breast tissue, that doesn't mean we stop screening the way we were screening. So once you're done with your breast cancer treatment, we go back to screening. We go back to screening you the same way we were before with mammogram and MRI because there's still breast tissue there. We still want to make sure that you're not going to have a second breast cancer at some point in time. So some risk-reducing ways that I know you've probably heard about in the news because Angelina Jolie had bilateral mastectomy for risk reduction for breast cancer is a mastectomy and a sapling oophorectomy, meaning we remove your ovaries and your fallopian tubes. So typically we like to see this between the ages of 35 and 40 for the ovaries and the fallopian tubes, or when you're done with your childbearing years. And then mastectomy, they usually say before 40, but you need to talk to your doctor about this. You need to discuss the options for you. You need to discuss for mastectomy, reconstruction options, and the degrees of protection, because if you do this earlier, it has greater protection qualities than later in life. So if you're 60, maybe not both of them are required. Maybe only one or maybe none. It just depends on your personal situation. But if you have this family history, if you have a genetic mutation, then you want to talk to your doctor about this and look at the numbers because the numbers change based on age or which one. Some people do one and not the other. So you can kind of sit down with them and figure out what is the percentage of chance of not getting breast cancer or ovarian cancer if I do these things. It reduces it significantly but does not completely make it go away as a chance, but it does improve it greatly. So we'll move on to breast density. So breast density, when we call it density, and we'll show you a mammogram here to explain a little further, but the dense portion of the breast is the fibroglandular tissue in the breast, which consists of ducts, lobules, connective tissues, and things like that. And that's kind of the white part of the mammogram on the x-ray. Fat appears black on the mammogram, so we're going to look at one here. So breast density increases means that there's more of the fibroglandular tissue than the fat. And for instance, when you get pregnant, if you've ever had a baby, you'll know that your breast tissue seems to expand and get ready to be able to produce milk and stuff. And so your breast tissue can wax and wane with that, with hormones, with many different things in life, with what you eat, and multiple other things. So this is an example of breast density. So here is a non-dense breast. Here is a dense breast. So we see all this white tissue here. That's all that fibroglandular tissue. And here, all the fibroglandular tissue we see is here. Now, that's not saying if you have non-dense breast, you're not going to get breast cancer, even if there was no like fibroglandular tissue seen. It just means that it's kind of involuted. And so we don't see it as prominently as we do here. And I will tell you, I have 80-year-old women whose breasts still look like this. So aging does change your breast, and a lot of times we tend to get less dense with age, but not everybody. So as I always tell my residents and medical students, you know, not every patient's body read the medical textbook that you read. So meaning that just because you read it in a book and this is supposed to happen doesn't mean it happens to everybody. So that's where the art of medicine comes in as opposed to just the science. So here's kind of when you're getting your mammogram, when you read the mammogram that we read, the first line under the findings will tell you what your breast density is. So you'll literally say fatty replaced, meaning there's more fat than there is fibroglandular tissue. Scattered fibroglandular tissue, meaning, as you can see here, there's probably more fat than tissue, but there's more of that white tissue here than here. Heterogeneously dense, so we have a lot more white tissue than fat there, and then extremely dense, where it's, you know, hard to really even see through the breast. There's very little fat, and it can actually be even more, like I've had breasts where almost all of this is white, and there's very little fat in there at all. So the people who are heterogeneously dense and extremely dense make up the population of people which we consider dense. Now you can flip between all of these through life. You lose weight, people get more dense. You gain weight, you get less dense. So, you know, just because one year you had one that said scattered, the next year you can have one that says heterogeneously dense. So it can kind of go back and forth depending upon hormones, and you know, if you start taking a hormone replacement or taking birth control, those things can change. Things get pregnant, lactating, all of that. So here's kind of the curve for who in the population has what. So you draw a line in the middle. 50% of the population has dense breasts. 50% of the population has non-dense breasts. The people who are predominantly fatty and the people who are extremely dense are 10% of the population on each side. So a large amount of us fall into this category where we're kind of in between. So where you may see yourself on your mammogram report flip back and forth is most commonly between scattered and heterogeneous. You know, it's an easy flip. You know, it's like 5 pounds one way, 5 pounds the other way. You can tilt the scale. So what are the risk things that affect your breast density? And this is a very short list. There's probably many more things that are being studied. You know, I know there's studies out there looking at what you eat, making a difference for that, and differing things like that. So I don't think we fully have the whole list together yet, but we don't have any research on much else than this, for sure. So getting older, once again, something we can't stop, can decrease your breast density. But like I said, doesn't happen in everybody. Gaining weight can decrease your breast density. And tamoxifen, which is a breast cancer drug we give to women after they have breast cancer, also will decrease your breast density. Not a reason to take it. Not a reason to gain weight to decrease your breast density, okay? I'm not promoting weight gain. What things that increase your breast density is weight loss, exogenous hormones, more, not so, birth control can, but more the hormones we give women if they have a hysterectomy and they're really young and we've taken their ovaries. Also, we may supplement some hormones just because of bone loss happens if they're like 30 when that happens, and supposed to, you have probably another 20, 25 years before you'd actually hit menopause. And lactation and pregnancy, of course, increase breast density. So this makes it an independent risk factor. Remember on those risk factors I told you, I said breast density was a risk factor. So if you're in that heterogeneously dense category, it increases your lifetime risk by like 1.2. If you're in the extremely dense, it's 2.4. So the extremely dense category is a little more higher risk than the heterogeneously dense category. But they still both have a small relative increase in getting breast cancer, mostly because if that breast tissue is all dense, that means it's probably a little more active than those of us who have less dense breasts where a lot more of it's involuted. So you're just seeing more activity, which can make for cancer to grow better because those cells are active. So the other bigger concern, I think, on the breast density thing is that it can change the sensitivity and specificity of your mammogram. So a woman with a fatty replaced breast, her mammogram is 97 to 98% sensitive, meaning If there's a cancer in there, 97 to 98% of the time I'm going to see it. And a woman who's extremely dense, it drops to 30 to 48%. So you really lose a lot of ability to see through that because, as you saw on both of those, which one do you think you'd find the cancer more easily in? The one that was less dense or the one that was more dense? The less dense one. Now, granted, I'm a specialist. I look at these all day long. I have a really fancy computer that helps me that's got great resolution. But all of that doesn't necessarily help see through something I can't see through. It's like trying to look through a muddy window and tell you what's inside. So here's an example of that. This breast I would consider heterogeneously dense. The only thing telling me there's probably something wrong here is this lymph node up here that doesn't look right. That probably is the reason she got further investigation. And then we found this right here is not normal. This hypocoque thing with all the shadowing, that's a breast cancer. I will tell you, it's living right here. I can tell you that because I know, because I looked at the biopsy results, and I can see where the biopsy marker ended up. But I can't tell you, looking at this mammogram, where that was. I would have never found it. Even in retrospect, knowing there's something in there, I still can't find it. So that's what breast density can do. It kind of can hide the breast cancer. So why we now have a breast density law in the state of Ohio. And the reason for that is there was a lady named Nancy Capello who was out of California who got breast cancer because she palpated something. She went in, she had a mammogram, she had an ultrasound, they found the breast cancer. And then she found out later that she had dense breasts, and she never knew that. And so she felt that women should find out if they have dense breasts or not. And they should know this because it does increase their risk, and it also causes that masking effect. So she felt that was really important. So she started this breast density law, and honestly, every time I open up the computer, we get a couple more added states. So when I first started talking about breast density, it was about like 19 states, and now we're up to 30, which is awesome. So what that means is that we are required by law, when we say you're heterogeneously dense or extremely dense on your mammogram, we're required by law to put a little blip at the bottom of the letter you get from us saying your mammogram's negative, whatever. There'll be a little blip at the bottom talking about how you have dense breasts. You should have a discussion with your doctor about what that means for you because, like I said, it's a small increased risk, but if you have any of those other risk factors, it might be a bigger increased risk for you, and it starts a conversation about this with your physician. So the laws don't dictate how we tell you. So you may go to here, go to the Spielman Center, and we have one blurb. And you may go to our competitors up the streets, that shall not be named, and you may get a different kind of like little blurb, but they're going to tell you somehow, some way, what that means to you, okay? So it's not like a specific verbiage we have to use. 6 states in the United States who have the breast density law also have a law on insurance, meaning that they should cover supplemental screening. So 6 out of 30. So 24 states don't have a law saying your insurance company has to pay for any supplemental screening. Supplemental screening can be whole breast ultrasound, MRI, tomosynthesis, which I'll touch on in a minute, and just getting clinical breast exams yearly, things like that. So unfortunately, here's a good example. So the hot pink is all the states that have the breast density law. The purple ones have an effort to inform patients, but there's no law. So they're kind of trying to do the right thing, but there's no law stating they have to. The blue states have an active bill. The yellow states have an inactive bill. And then the states with the little diamonds have that insurance law. The only catch with the insurance law is that not all insurances have to actually subscribe to it. So there's this law, and some insurances have to follow it, and some don't. So I guess it's better that you have the law in your state, but it doesn't necessarily mean that all insurances have to follow it and actually cover everything. They may be able to dictate which supplemental screen you get. So in Ohio, we currently do not have that. So if you have dense breasts and that you want a supplemental test, you'd have to talk with your insurance company to see if they actually cover it. So let's talk about what it means to get screened for breast cancer. Some of you in the room, like myself, have probably had a mammogram already, had the pleasure. Some of you probably have not. But this is what a mammogram machine looks like. So your breast would set here, and this paddle comes down, and we compress the breast. And then the picture is taken by this little camera all the way up here. There is 2D mammograms, which I'm going to show you a picture of here. That's a 2D mammogram. And then there are these 3D mammograms, otherwise known as tomosynthesis. So when tomosynthesis is performed, the mammogram machine is going to look just like this. The only difference is instead of this thing staying straight like this, it's going to arc in about a 15-degree curve and take pictures. it really, you as the patient wouldn't really notice much more than maybe a 2 or 3 extra second breath hold than what you normally do for a mammogram. In fact, I have it done every year. The nice thing about tomosynthesis, meaning it's 3D, why do we call it that? It's because instead of having this static 2D picture, and this is all I can look at to see if something's wrong with you, I get that 15-degree arc taking pictures gives me 1 millimeter slices through your breast. So it's kind of like a CT of the breast. Tomosynthesis has been around a really long time. It's an old technique we've used for many years in radiology, just not with breast imaging. It's kind of been revived. It was kind of the precursor to CT, and then CT came along and everybody kind of forgot about it. And now we've revived it in breast imaging. The beautiful thing is, if they do, like currently at the Stefanie Spielman Center, we take a 2D image and a 3D image, but we are obtaining software that allows us to just take the 3D image and it creates a 2D image in reverse. So if you have to have the 2D and the 3D image done together, it takes the radiation exposure up double what your mammogram is, which is still way under your daily allowance of dose. It's about the same as flying from here to San Francisco. You get the same amount of radiation doing that. Once we implement the software we just obtained and we just take the 3D image, it goes back down to the same radiation as it was with just the 2D images. The reason I tell you this is if you have dense breasts, this tomosynthesis is really good for you. Even the people in the scattered fibroglandular, which actually I am a part of, you really see through the breast much nicer. And we can get through all that masking effect a lot better. The extremely dense people, sometimes it's really good for you, sometimes it's not. It's kind of one of those things we have to try to see if we have enough fat kind of interspersed in between all that tissue to give us good resolution to see something. But if it's super dense and it's all white, it probably is not going to work, but it's worth a try to see if we can see through your dense tissue. So when you get a mammogram, whether you get the tomosynthesis kind or you get the 2D kind, you get a CC, which is cranial carotid, meaning we go like this, and the radiation comes from top to bottom. The other view is called an MLO. So we kind of go from medial to lateral, and we kind of do it at an angle. The reason for that is we get more breast tissue from the medial aspect of the breast and the lateral aspect of the breast and get more of that pectoralis muscle in there. So when we're screening you, we can actually get more of your breast tissue in those two views than we could if we just went straight medial lateral. So let's touch our last part in this talk is about breast cancer screening and all of the different recommendations that are out there that confuse everybody, that I get asked about quite often. So I'm going to start off with what I believe and what I follow, and that is what the American College of Radiology states, the National Comprehensive Cancer Network, which is the NCCN, which are those guidelines we talked about earlier, and the American College of Obstetrics and Gynecology all recommend patients start annual mammography screening at the age of 40. And from 40 to 49, we get annual screening. From 50 to 74, we get annual screening with mammogram. And after the age of 75, then you talk to your doctor, kind of for the same reason we talked about the genetics and further screening there. Nobody's made any final decisions on anybody over the ages of 75, so you should have a talk with your doctor and see if you want to continue screening or if there's a reason you shouldn't, and you guys make that decision together until better research comes out on that. The American Cancer Society came out with some recommendations saying that when you're 40 to 44, you should be given the choice of whether you want a mammogram or not. So kind of up to you and your doctor. From 45 to 49, you should start to get annual screening. And then at the age of 50, you should start to every other year screening. But you still get the choice of doing annual screening. And then at 75, you can continue it as long as you are in good health and your life expectancy is greater than 10 years. Then there's the United States Prevent Services Task Force and the American Academy of Family Physicians and also the American Academy of Internal Medicine kind of follows whatever the United States Task Force recommends. They say from 40 to 49, starting annual screening should be your choice. 50 to 74, then you should get screening every other year. And then over 75, they don't have any recommendations because there's not enough research. So why do I recommend annual screening? Because I do this every day. I see women younger and younger getting breast cancer. I literally last week diagnosed 5 girls in their 20s with invasive breast cancer. Not that I'm saying we start screening at 20. It's kind of an oddball thing. But I have, over my career so far, seen things get younger. So waiting to 50, in my mind, is waiting too long. So I think 40 is a good age. It's a good safe age to start getting mammograms. Your risk from radiation, which I talk about a lot, is really not that big. You get background radiation all the time from many other things, probably even our cell phones. But this is very small blip as far as that goes, especially if you're worrying more about cancer and dying on the other end of it. The United States Task Force is, when they make their recommendations, and I've done a lot of talking on this in the national news and the local news, they make these recommendations and then they give them these codes. They say A, B, C, and D. So if you read their article, you'll see they say A, B, C, and D, so they have recommendations. So in this, where they recommend women 40 to 49 should be given the choice, but they give that a category D, or a category C. Category C and D to your insurance companies mean we don't have to cover it even if you want it. Category A and B mean they have to cover it. So even though you're given the choice according to their recommendations, you can do it if you want to pay out of pocket, if your insurance company won't. But I think that you should be given the choice and your insurance company should still have to pay for it, but they don't have to if it's a C or a D recommended by the government. So that's my issue with that. There was a act put in place when this came out a couple of years ago. Every time they make these recommendations for the United States Task Force, there's a little act that's put out and basically tells Congress to put on hold, like putting this into law, waiting for us to be able to, have a little bit more research, a little more talk. I've read every one of their references from their article and what they were referencing stuff. I think there's better references out there to defend having screening mammograms. Their biggest problems with screening mammograms is overdiagnosis. They talk about a lot, meaning that we are finding more stuff because our mammograms are getting better, right? And we're biopsying more women. And in that, we find things like those high-risk lesions I talked about, and DCIS, they're lumping it in the category. Well, those high-risk lesions aren't really considered cancer. They can become cancer. The DCIS is considered a cancer, and it can become invasive and more likely to become invasive. Of that, when they lump those two together, we get a 10% overdiagnosis. If we take DCIS out, it becomes like a 1 to 3% overdiagnosis. However, we don't know, because under the microscope, we can't tell you which one of these high-risk lesions or DCIS is actually going to become an invasive cancer and kill you. So we take it out and we treat you. And so that's, as a woman, until you can tell me it won't become anything, I kind of want it treated. Personally, that's my personal preference. But the other thing is they worry, say, anxiety. Women are anxious. We call you back from a mammogram. It's kind of scary. And we tell you have to have a biopsy, and that's really scary too. But there's been multiple studies done, and every woman I've ever talked to tells me, yes, I was really nervous, I was really scared, but when I got the results that it was benign, nobody's mad at me for doing that biopsy because they know they're okay. Or if it was malignant, they're like, okay, now I know what I'm doing, and I can treat this, and I can be okay because we caught it early. And the whole idea of screening is to catch this stuff early so you don't have a later stage cancer. So those are their kind of big two reasons why not to screen, which in my mind really aren't, until we have better way to look at pathology to tell you what your really risk of these things actually becoming something are not something I think is a good idea for the population. And like I said, since the 1980s, we've seen breast cancer mortality drop 40% since we started a screening program. And I will tell you that in the literature, the women who present with cancers that are more aggressive and likely lead to death are women who aren't getting screened regularly. They're of the population. Even though we have this screening program in the United States, still there's a 20% of the population not getting screened annually. And so for screening, you don't need a prescription for screening mammogram. You can walk into any facility and you can get a screening mammogram. Once you need a diagnostic, we have to look at something further because there was something wrong, then we will call your doctor and we will get a prescription for that. But you can get a screening anytime you want, anywhere, as long as you're over the age of 40. If you're under 40, you do need a prescription. So those are my references. Questions? Anybody? Usually you need to see someone in the high-risk clinic to, first of all, figure out whether or not your risk factors add up to something you need to be tested for it. And then it's a blood test that they do. And that usually includes the BRCA gene, and then if there's other gene mutations they're really worried about, it'll incorporate more of those. But over-the-counter stuff, if there's stuff out there, which there could be that I'm unaware of, saliva testing, it's probably not as accurate as the blood test. Oh, you mean if it's something that we haven't biopsied, but we think's probably benign? Okay, so when we find something that we think's probably benign, we have to have a less than 2% suspicion that we think it's a cancer, which is really small, narrow window. So that's why, you might get asked to get a biopsy. But if we feel that way, you have a really, small chance of us being real worried about it. But we're still worried enough that we want you to come back and make sure it's okay. So the usual thing for that is 6 months follow-up, and sometimes that's just ultrasound, sometimes it's mammogram and ultrasound, sometimes it's mammogram, depending on what we're talking about. And then we usually ask for another 6 months, so that puts you at your year mark. And then after that, we want a 2-year thing, so a lot of times we push that out to 12. If it's been stable in a year, we'll wait and look at it one more time at 12 months. But after 2 years, you're pretty much okay. Yeah. Yeah, everything's, because the moment the size changes, we're going to biopsy it. So, you're welcome. Any other questions? Okay. So right now, I'd recommend you ask for the tomosynthesis when you come. All of our sites have tomosynthesis, and almost a lot of all of our competitors still have tomosynthesis. It's something we ask if you want, because, and check with your insurance company, more and more insurance companies are covering it. I mean, since last year to this year, it's astronomical how many more insurance companies are covering it, but you should call and ask them. If they do not cover tomo here at our facility, it'll be a $140 upcharge. So you'd get a bill for $140 if they don't cover the tomo. Some insurances are covering parts of it. I expect that to change. They're all starting to cover it more, but we actually just got involved with a TMIS trial, meaning it's tomosynthesis, mammography, and screening trial, which is going to take a good 7 years to finish, but it's the same thing we did when digital film came out instead of screen film, when we used to actually carry around the pictures. And we proved for digital that digital was better than the screen film, and I think we're going to find out that tomo is better than digital. We just have to prove that, so that then everybody gets covered. But in the meantime, check with your insurance company. We do have a running list at the Spielman Center of which ones we know are covering it. Ohio State does, so I would start there. If you're extremely dense, we are eventually, and it's not on board yet, but eventually we will be doing whole breast screening for the extremely dense category if the mammogram is not being as productive as we would like. But we're still 6 to 8 months out for that to start. And once again, with that, as I talked about the supplemental screenings, you want to check with your insurance company because they're not all covering everything. Any other questions? Well, thank you guys for having me. You guys have a good day.
Just a couple of quick announcements. Please fill out your evaluation forms. You can either leave them on your chair or leave them with myself or Nicole on your way out. We also have plenty of biometric screening appointments that are available for walk-ins. So if you got your biometric screening, but you know somebody else that hasn't gotten their biometric screening, please communicate that to your department. I'm sure there's somebody out there in your unit that hasn't gotten their biometric screening. Also, feel free to stop by Michael out here. He has some great info from the health plan about upcoming events.